So firstly, thank you very much, Mary, for the invitation to present at the Physiological Society. I have great respect for the Society, having done my PhD here and gave my first talks at this meeting many years ago. Before I begin, I'd like to acknowledge the major contributors for the whole of the presentation, but in particular, Kevin Grace, who a PhD student who's now at Harvard, and Andrew Wellman, who's at Harvard. That's the bulk of my talk, and contributions from the other people mentioned. I'll also indicate that there are no conflicts of interest in any of the materials that I'm going to present. Firstly, I'd like to highlight that in most advancements in the medical sciences are rooted in a base, a fundamental, and in many cases large base of basic knowledge, and there's translation up to the clinical findings and interventions and their application. But respiratory sleep medicine is different. Particularly with sleep apnea, discovered as a clinical entity, there's a large expansion of clinical sleep laboratories throughout the world, but the basic science knowledge underpinning a field like sleep apnea has been slow to progress, and this has made, in some cases, a wobbly foundation of how to inform clinical findings beyond the excellent ones to do with treatment which exist. And the basis of the thinking that not only my lab but other labs, and in particular for sleep apnea, is in some way to widen this knowledge base. And the idea is that this can open up a new pipeline to clinical practice and application. So there's advancements both at the top of here, and some of which I'll mention, so that's close to the patient, but there is room for increase in the basic knowledge base to not only for the pipeline to new therapies, but also to support new therapies. So one of the ideas, what I'm going to talk about is not going to replace necessarily clinical interventions that are very useful, but things like CPAP, they're very effective, but people stop using them. So if it's possible to have an adjunct therapy that maybe can massively reduce CPAP pressures, say from 10 to 2 to 3 or 4, and have equal therapy, people might use them longer. Or alternatively, if some treatments are very effective, you might have the ability to withdraw CPAP and continue treatment in a different way. So there's 4 main factors that contribute to sleep apnea pathophysiology: anatomy, neuromuscular compensation, arousals from sleep, and a phenomenon called loop gain, which predisposes to respiratory instability. And one of the big clinical outcome points that we have now is that basically people might have the common entity of sleep apnea, which presents quite simply. It's an airway obstruction behind the tongue, leads to asphyxia and arousals from sleep. But how an individual patient gets to that point is different from patient A to patient B. And how, for example, the large predisposing factors like anatomy, which is also influenced by neuromuscular activity, but also the neuromuscular compensation mechanisms which always also kick in. Individuals are in some position on this spectrum, how easily the airway shuts. And if one can improve anatomy through neuromuscular activity and the neuromuscular responsiveness, one can maybe dial down an individual along this scale such the airway is harder to close. So the first strategic decision in dealing with thinking about alternate treatments is to phenotype patients and identify those that may respond to a particular intervention. Certain patients who might respond to neuromuscular interventions would be very different from those patients who might be influenced by factors influencing loop gain or arousal. So that background leads to the focus of this talk, which is essentially on upper airway motor control. And for the tongue muscle, this is from the hypoglossal motor nucleus in the medulla. And there's a phenomenon both in humans and animal models where one can record, say in rodents, EEG, muscle tone, tongue muscle activity. Each one of these individual peaks is a breath in the diaphragm. And you can measure state-dependent modulation of motor output. Here, for example, to the major muscle of the tongue, which causes sleep apnea in humans. But the question is, what causes it? and to try and identify and develop models which you can identify normal physiological mechanisms and perhaps then ways to modulate them. So over the years, the major body of work from my lab in Toronto has been to identify what these mechanisms may be. And before we did these studies, there really was no studies that would allow you to infer what mechanisms are operating and which ones to target. So over the years, we've identified the role and physiological role of alpha-adrenergic receptors, histamine, serotonin, the glutamatergic system, cholinergic, GABA and glycine systems. Now, a lot more work on particular channels of interest, some of which I might mention. More recently, with some studies I'll describe, use techniques using DREADS, and you'll see why. And most currently, which I don't have time to talk about, is the use of optogenetics in a different way than most people use them, and ours is to actually quantify excitability of this pool across states and identify tools that can be used clinically, future clinical use, to modulate excitability in a positive way. So the idea here is to really increase this knowledge base, have a pipeline to the potential clinical applications with things that are useful, then feed back to accelerate discovery by increased focus on the things that are relevant. So I'll give you an example. Here I showed you before this large suppression of tongue muscle activity going from non-REM to REM sleep. And the question had been in the field for a long time, well, what causes it? And the prevailing thoughts, for good reasons, was it was through inhibitory glycine and GABAergic input, which we know from the control of postural motor pools in the spinal cord, is the inhibition of the spinal motor pools is through GABA and glycinergic inhibition. There's been an evolution of how we understand REM sleep, but regardless of what mechanism regulating REM sleep one has favor in, the GABA and glycinergic inhibition of motor pools is common to both. So the question is this the case operating at the hypoglossal motor pool? So one of the first studies many years ago was to influence the hypoglossal motor pool directly. And one would ask the question, if this large inhibition that's clearly apparent going from non-REM to REM sleep is through GABA and or glycinergic inhibition, then if one blocked it, one should be able to release motor inhibition in REM sleep. In black, we have normal tongue motor activity from wake to non-REM to REM. And in the presence of GABA and or glycinergic inhibition, you can see there is large increases in tongue motor activity, but it's trivial in REM sleep. And in fact, if you came at this a priori, you would not expect this result, unless you were to infer differently that there's a tonic GABA inhibition, tonic glycinergic inhibition that you release by blocking it. This is really minimal evidence that there's an important GABA and or glycinergic inhibition operating at the hypoglossal motor pool in REM sleep. We had reason to, several years later, to be interested in the role of cholinergic input. And here we have on a different scale tongue muscle activity in wake, non-REM and REM. You can see the large motor inhibition in REM sleep. It's not caused by GABA and or glycinergic inhibition. What happens if because nothing happens when you block it, but if we block cholinergic inhibition, we have basically rescued tongue muscle activity in REM sleep, and it basically brings it up to levels that you would normally experience in wakefulness. You've completely prevented this inhibition, and you get very much smaller, if any, responses at all in the other states. These are small examples. We've also done further studies, though, over long periods of REM sleep, minutes or the whole REM period, and we've also linked this to a potassium channel mechanism. At the time, I don't have time to show you. What I can show you, the big difference in the responses to GABA and glycinergic inhibition in REM compared to muscarinic GERK channel mechanism. We can restore activity in REM to levels that are normally present in non-REM sleep and even approaching those that are present in wakefulness. So these papers were published, and we identified, of all these things operating, the major players modulating tongue motor activity from wakefulness to sleep, and in particular REM sleep, was a acetylcholine-GERK channel-mediated REM inhibition and a noradrenergic excitation that's present in wakefulness and is withdrawn in sleep, especially REM. And there's also a glutamatergic contribution, which I really don't have time to talk about. So I got a phone call from Andrew Wellman at Harvard. He was very interested in these two papers in particular, asking me whether I thought that a clinical intervention that would modulate these two mechanisms that we had identified operating in rodents would be potentially clinically useful. And I had to say, Andrew, I'm not sure. If you see a positive response, it could be operating through this mechanism. If you don't see anything, it could be because they're acting all over the brain or for whatever negative reasons. So I don't know, Andrew. I can't give you any encouragement positively or negatively. The thing about the need for a combination therapy, though, is because if you were just to apply, for example, a noradrenergic reuptake inhibitor, you might see what you see here, which is if you have noradrenergic stimulation of the hypoglossal motor pool, you can increase tongue muscle activity in sleep, but then REM sleep comes along and this powerful inhibitory mechanism just switches it off. So despite the fact you've got this noradrenergic excitation that can be powerfully stimulatory, REM sleep comes along and presumably by this cholinergic Gurk channel mechanisms just switches it off. But Andrew did proceed. He did two clinical trials, and the one I'm going to just show you the data on is this one, where he gave this combination of drugs, norepinephrine reuptake inhibitor and an antimuscarinic agent, with the idea to block this cholinergic inhibition at the same time allow for noradrenergic excitation. And this paper was only published, I think, in September. And actually, this report from a reporter in Science preceded the formal publication because they presented this work in Paris first. But this is a figure from that news article showing how these drugs are thought to work. But the clinical data are the more important thing. So here we have as a group of, I think, 20 or 25 patients. And I have to say, I was actually surprised. Andrew wanted to show me this data before it was formally published. I didn't really want to see it. But when I was published, I was both surprised at the magnitude of the clinical effects and their consistency. So here we have the apnea-hypopnea index recorded with placebo and with this combination of drugs. And apart from this one patient here, every one of them responded. And there was a positive response in both non-REM and REM sleep. The second thing that surprised me was, I showed you before, is that different patients have sleep apnea for different reasons. And in some, you may expect them not to respond so strongly to a clinical intervention than others. This was all comers. They weren't pre-selected or phenotyped, so this was really rather a surprise. So let me move on and see where we might go from here. So this was a review that Mary and a couple of others asked me to contribute to, and we got tired as an author of just writing about things that are already published, so we wanted to do something new in this review, so we tried to tackle something differently. So one of the things we do is to ask the question, well, what might be viable targets for sleep apnea pharmacotherapy beyond, for example, the approaches that I described to you just now? So we decided to do, as a first pass, a review of the Allen Brain Atlas, and to identify from high-quality studies the hypoglossal, what's operating at the hypoglossal motor pool, but also from other studies, premotor inputs that have major identified afferent inputs to that hypoglossal motor pool. And from that, we did a screen where we identified genes having at least, this was just an arbitrary distinction, at least twofold expression at the hypoglossal motor pool and the hypoglossal premotor pool compared to all other brain regions. From there was nearly 1,500 candidates, which we then mapped onto a database of molecular function to identify those genes which were probable modulators of neuronal activity with human analogs, of which there were 99. 37 ion channels, 18 G protein coupled receptors, and 44 others, meaning, for example, enzymes. And we then mapped them to the database of FDA-approved drugs from the human genome. And there were 9 genes, 13 genes, G protein coupled receptors, and 4 other. and then map them to the database of drugs that have been tried for sleep apnea. And I just show you the database in its entirety. I recognize that certain things won't be readable. But these are, for example, the position of the alpha-adrenergic receptor and cholinergic receptor on this list. Some face validity because this has been tried and are positive in the treatment of sleep apnea. There's things that have not been tried so far that are really quite interesting. Thyrotropin-releasing hormone, for example, I'll mention that at the end. Urotensin-2, never been studied as an agent to modulate motor function, but it's a powerfully excitatory agent. We've done some preliminary studies with that. Things of interest are monoamine oxidase, certain voltage channels. We've done a lot of work. I don't have time to talk about certain potassium channels that have also led to some clinical trials, and one I will mention just briefly just now. So this channel is really interesting. This is number 2 on the list of most highly expressed channel at the hypoglossal motor pool. This area of interest with respect to sleep apnea. If you look at the Allen Brain Atlas, here's the hypoglossal motor pool, but the KR2.4 is expressed for some reason or other only at the cranial motor pools, and the cranial motor pools provide stability and activation of the upper airway muscles. It's really interesting. So this is a highly restricted channel. It's hard to drug, and there's no drugs in the public domain that can modulate it. So instead, we kind of stepped back and said, well, okay, let's, instead of having a receptor that's put in, a channel that's put in place by nature in areas that would be relevant clinically, let's step back and maybe put a receptor in those places instead and modulate it with a designer drug that only influences that receptor. This is the designer drugs exclusively activated by, designer receptors exclusively activated by designer drugs method, DREADS. So here, you can't really see it very well because of the lighting, but in red is this designer receptor at the hypoglossal motor pool. You give CNO systemically. It only affects that agent. We showed it didn't do anything by itself. And you can see you can activate the tongue musculature with systemic injection of this drug that's only impacting the receptor that we've specifically put in place. And it does so in REM as well as non-REM. And the effect lasts for hours. And the effects are specific to the tongue musculature. We see no effects on any other related variables such as respiratory rate, diaphragm amplitude, postural muscle tone, or sleep-wake distribution. Just finish with this last data slide with respect to thyrotropin-releasing hormone. Very interesting agent. A lot of the biology or physiology of thyrotropin-releasing hormone is known because of its role in endocrine physiology. But most of thyrotropin-releasing hormone is located outside the brain. It's strongly involved in neuromodulation of motor function and cognition. And there's a human analog of thyrotropin-releasing hormone, which is taltarelin, which is approved for human use in the treatment of neurodegenerative disorders. And we've recently characterized that this is a potent excitatory modulator of hypoglossal motor output when delivered locally to the hypoglossal motor pool. But if you give it systemically, you can also increase tongue muscle activity over a sustained period of time in sleep, purple versus gray compared to the vehicle, as non-REM as well as REM sleep. And it's never been tested as an agent for stimulate sleep-disordered breathing. It's been talked about, but I do think this work will actually also lead to a phase 1 clinical trial. So with that database, I'll leave you with this idea. You can look up the database itself. We have published, but we've also annotated it. So one can look for certain agents. Each number on this wheel is one of those candidates. The number of drugs which are available, their targets, and those that have been studied in the context of sleep apnea. So I think even though this has an Austin Powers type color code, it's the sort of thing that can be sat down with your beverage of choice to be interrogated and lead to some new ideas for linking basic science to clinical medicine. And with that, I'll thank you for your attention.
Excellent. Thank you very much. Questions? We've got time maybe for 1 or 2 urgent questions, yeah?
Yeah.
if you give an anticholinergic drug, do you think that you could be able to target specifically to the upper airway muscles, or don't you think that you might have side effects like increased muscle nocturnal tone or inducing parasomnia? Do you think that you can refine specifically the action?
So there's two or three directions really. One is to go the established route based upon precedent from the animal literature to say that these mechanisms are operative. If one affects them, they might have effects which are beneficial. The study I described to you, they did not have any adverse clinical side effects, but that intervention was carried on for a week, and they chose the doses carefully. How that I know that they've generated a large amount of money to do a larger trials, which is important, and they may phenotype patients to see which would most benefit. That's one thing there. The second thing is to, I think, to use a database like that and say what other things can be tried that either are very, very specific. I personally think that the KR2.4 is a really powerful agent to go for, but I know it's very, very difficult. And the third thing with the interventions is to know more about the chemical phenotype of the cells. It's known for some of the premotor drives that go to the hypoglossal, where there's been chemical phenotyping of certain cells. So you may be able to target with something that will be useful, but only target those cells that are making the difference. The same is not true for the hypoglossal, but there are avenues forward. I just think we're at a very early stage.
There was this very beautiful paper in Science, I think, that showed that central control of breathing changed between slow wave sleep and light sleep. Is that right? Or maybe
well, it
I'm
depends
wrong.
Which one you're
the
referring
central
to.
with a retrotrapezoid.
All right, okay.
I can't remember exactly.
Yeah.
And then they identified specific targets on these neurons as well. So this is not something you have been talking about, but the fact that sleep apnea is much worse during light non-REM and during REM, but certainly light non-REMs and deep REM. And I'm just wondering if you think there's something there, or...
Yeah, I do. I mean, the phenomenon about the sleep apnea being kind of going away in deep sleep has always been whether that's the chicken or the egg. So
yeah.
Because, but people, once they have sleep apnea, they don't have sleep apnea all the time. So there's something about they self-cure themselves and whether it's going into deep sleep. And that's the rationale for having sedatives as one of the target aims that people go for. So it depends on how far upstream one wants to go. So the further upstream one gets, the level of uncertainty becomes about how an intervention will impact the thing you would like it to impact more directly versus all the myriad effects that you might sleep. Arousal is very important. You don't want to get rid of it, but you might want to delay it a little bit to allow people to get into deep sleep so they don't have sleep apnea. It's a tricky area, and that's why I think to focus on the motor output is the last place that is relevant to the motor activity, and that's why.
You could also argue that people breathe normally during wake.
Well, that's the point. So if you're going to normalize this, so that's where the optogenetic assay that we have is to measure excitability as a function of state and have more of a high throughput, these are long experiments, to have a more of a high throughput screen, if you can have a high throughput in a rodent model, but to have a way to actually measure excitability, how it changes, and then normalize it and do it that way.
Thank you very much, Dr. Horner. And we got to move on to the next speaker, please.